So I'm Lisa Berkman, and the principal investigator of the Harvard site and a social epidemiologist. I will give you some of the background and rationale for the study building on what Roz King has just provided. So the funding, as we said, is from a number of organizations, and I will just skip over that and talk a little bit about the historical background and demographic changes that Roz alluded to, and some of the evidence that work-life demands have really long-term effects. So there are some gaps in the evidence we'll talk about, findings from the initial pilot studies that were described very briefly, and background and rationale for the study. So one of the things that's been most striking to me is life expectancy at birth in the United States. Over the last 30 or 40 years, the United States has gone from ranking in the middle of OECD countries in terms of life expectancy. There you see them just in the red dots are the United States, about in the middle, to, by 2006, at the very bottom of OECD countries. So women's life expectancy has continued to improve over time, but very, very, very slowly. And in fact, what's happened is that virtually every other country has overtaken us during this time. And one of the really big questions is what accounts for this? What happens? So there was a National Academy of Sciences panel to explore exactly this issue. I was a member of that committee, and at that time, nobody brought up work or labor practices or fertility or family dynamics. We looked at all the usual suspects: smoking, obesity, alcohol consumption, medical care, but we didn't ever delve into what actually I think we collectively think is potentially one of the most important drivers. So the motivation was, as many of you know, increased labor force participation of women during the second half of the 20th century. Working women with children early on made up about 38% of European workforce, and now it's up to 71%. And this is true in the United States as well. So if you looked at 1970s, 1980s, or even farther back, 1950s and 60s, when most labor practices were made, a very small number of women with young children were in the labor force. And this has been transformative over now. Over this period, to the majority of women who have young children are in the workforce. Starting in the early 1960s, many European countries enacted comprehensive maternity policies and many forms of social protection. The United States stands alone among virtually all industrialized countries in lack of work-family policies. And this just shows you some of the data. So on the far side, you see the share of mothers who are in the labor force, 71% today, 47% in 1975, and this is with children younger than 18, and slightly lower rates for women with children younger than age 3, but you still see the majority in the workforce. The other thing that's really striking during this time is the share of births to single moms. So what's happened over time is that if you look at 1960, 5% of births were to single moms, and this has now grown to about 41%. So a huge issue about how families are going to manage, whether they're dual wage earners or they're single wage earners, how this is going to play out. And this, of course, is the slide that shows formal social protection policies in most OECD countries. And if you can't find the United States, that's because it's way, way at the bottom here, and still lacks any kind of paid leave policies. So again, the goal of our network was to see if we could look at informal workplace practices and organizational practices around work redesign in the face of the fact that the United States is lacking any kind of social policy. And we had a sort of a theory about work-family strain in which work-family demands might be very high. We can think of this as parallel to job strain, classically thought of, where control is low and demand is high, that's a recipe for increased cardiovascular disease risk and many kinds of poor health outcomes. And when social support is lacking, whether it's formal or informal, that also adds. So in a sense, the United States collectively is in this high-risk quadrant. It's almost a perfect storm where fertility has stayed reasonably high in the United States or steady. Most women are in the workforce, so you kind of have high demands and actually very low control and very little support. So the findings from the pilot studies, as Roz indicated, we spent several years actually exploring both in observational and experimental ways how we might develop the larger goal for the work-family network, how we might put it all together. And there were 4 series of individual studies, each of which contributed a very important element to ultimately the planning of our network in phase 2, where we launched this very large randomized field trial in 2 major industries. So I'm going to talk a little bit about the one that we did at Harvard, and we looked at whether employees working in nursing homes who had supportive or not supportive managers had any kind of adverse outcomes related to how their managers behaved. So we interviewed, this is in about 4 nursing homes, a small pilot study of about 400 people. And again, as we said earlier, we embraced both qualitative and quantitative methods. I think one of the really strong points of our network is the integration of just super first-rate qualitative and quantitative data into our studies, coupled with even biomarker data. So in our study, we interviewed managers, and we asked them how open they were to work-family concerns, and how creative and flexible they were in managing work-life issues. Again, you should remember this is in nursing homes, which lacked any kind of real formal policy options for flexibility or anything like that. And we then looked at outcomes based on employees' self-reports and their biomarkers for cardiovascular risk and sleep, which I'll talk about. So our first set of findings, which really guided one of the most important elements of the study in terms of outcomes, was that we found that employees who worked for managers who were not work-family friendly had about a 2-fold risk of having high cardiovascular disease risk factors. And people who had friendlier managers or more creative and open managers were the reference group. So they're 1 here. So again, people whose managers, who worked for managers who were not open and were not creative or flexible, had this increased risk for cardiovascular disease. The other thing that was really interesting was the relationship between sleep. So one of the very innovative things that we did, and we'll talk about it more, was to measure sleep using an actigraphy monitor, and I'll show you exactly how that worked, but basically employees monitored, wore a watch that tracked their sleep and movement patterns very, very sensitively over a number of days, and then we could objectively see how long people slept. And what we found was that, again, people who had low scoring managers, that is, people who were not open, friendly, creative, flexible, slept almost half an hour less per night than people who worked for managers who were more open and creative in their approaches. And this is pretty staggering. As you can see, the absolute number of hours hovers between 6.5 and 7. Nurses are chronically, and nursing assistants chronically on the cusp of sleep deprivation. So half an hour is an enormous effect. This is a study that combines work from Penn State, where they looked at hotel workers. And what they found was that employees in more flexible work situations experienced fewer stressors in a number of domains. So you can see any work stressor is the total. Low flex workers had much, much higher rates for experiencing any kind of workplace stress, arguments at work, tensions, employee coworker kinds of stresses, hotel guests stresses, and then home and child stressors as well. So flexibility seemed also very important in the hotel industry. So the Work, Family, and Health study, in terms of overall aims for both industries, was a multi-site randomized controlled trial targeting work-life conflict with comprehensive multi-level measures to assess the intervention effects on employees, families, and managers. So I've now made this transition from our baseline sort of pilot phase studies to the phase 2 studies, in which we took all the lessons that we had from the pilot studies and moved into a collective study that the entire network was involved in. And their reference for this is an article by Jeremy Bray, who was head of the RTI site and is now at North Carolina University, to integrate all of these measures. The intervention, which Erin will go into much more, was to increase employees' control over their work time, increase supervisor coworker support. It included participatory work redesign activities, and then Erin will follow up and talk about this much more. This is a slide of the study design, in which you can see that as we moved into 2 industries, which we'll talk more about as we talk about each industry, we had a baseline wave where we collected, before the intervention, survey and health data. We collected spouse data, which Kelly will talk about, child surveys, daily diaries, and interviews, a whole set of data ranging among a number of people in a number of ways. And then we introduced the workplace intervention, in which it was delivered in this randomized treatment way, which we'll describe also later on. And then we had a wave 2 that was a 6-month initial follow-up at basically the end of the intervention to see what things looked like. And there we again repeated the survey and health data collection. And then we had a 12-month survey at wave 3, in which we repeated extensively the child and spouse survey and daily diaries and interviews. So that was a longer, more complex wave. And wave 4 at 18 months, in which we collected survey and health data again, and did interviews. So that was the overall study design. Again, as we've alluded to, this is an extraordinarily rich data set. Almost every sort of data is collected here. So if we look at this in terms of levels of analysis, we have data on the organizational features at the worksite level, so things that really exist only at the level of a worksite or a work unit. In some ways, then we kind of move down to a smaller area where we look at characteristics of the work team, performance, safety, climate, safety behaviors, work-family conditions, climate, and a whole set of costs. So that's kind of the triangle. And then we move into what is the circle of employee data, where we collect data both on the manager and the manager's characteristics, as well as the employee. So a lot of our data is at the level of the employee and the work site, within the work site, and there we looked at performance, attitudes, behaviors, perceptions, lots of data about job stress, work-family conflict, and physical and psychological health. And then we reached down even further, and this was the area that Penn State really focused on, to see what was important about family characteristics and how might worksite interventions influence family characteristics. So we looked at characteristics of the spouse or partner. We looked at parenting styles, parental stressors, and then characteristics. We interviewed actually children of the employee and asked a whole set of questions, and Kelly Davis will talk much, much more about that area. So you can see we range from organizational worksite all the way down to characteristics of individuals and their families. And there are two kinds of general areas where we focus on in terms of the interface. So we have a set of family supportive supervisor behaviors we call the FSSB that was largely developed at Portland by Leslie Hammer and Ellen Kosick and their crew. And then we have a series of work-to-family conflict and family-to-work conflict that focuses on the interactions at the level of the family. This is our data collection and timeline. So you can see, as Roz said, we had a phase 1 that started in 2005 and went for several years. And then we planned this very, very large intervention in 2 industries, which started in 2009, but actually we went into the field around 2010 to do the baseline survey, and then everything lagged 6 months as we started to do wave 2, wave 3, wave 4. And part of what we'll talk about later is the date and way that we will start releasing these data for people to be able to use. So we are about ready with wave 1, and the others will be released in sort of a chain as we actually finalize the data. And I want to talk a little bit about how complicated it was and how meaningful our data are to a number of people. So we very much hope that this will broaden the range of investigators who want to use the data and be meaningful to a whole host of people. So I always think this slide is actually maybe less helpful more helpful, but it does serve to show the complexity of things. So there's an administrative set of data, which are very, very important not only to us as scientists, but to people who are in the workplace, people who are in corporations who want to learn what are the outcomes of workplace redesign and organization for a series of administrative outcomes. We have a lot of process data. This actually is a study that's been very rich in qualitative and observational areas where we've looked at sessions and informal interviews with people. We've looked at the fidelity of the intervention. We've interviewed people in terms of qualitative work about the context of the organization and how it was perceived. And then we have a lot of data on both our manager works intervention that was focused particularly for managers, and again, more data on attendance and that kind of thing for people who did the intervention. And then we have this huge kind of green circle of employee workplace surveys where we have very rich data on health. So we have employee data that's self-reported and measured at the time of the survey. So for instance, blood pressure was assessed, height and weight. Then we have dry blood spots that we looked to observe a number of biomarkers and in fact still have them stored. We have employee actigraphy data, which are the sleep data that I was referring to later. And then we have all of this parallel at the manager level to do it. And then we have data on the daily diary, on the child daily diary, and a set of biomarkers, salivary measures to look at cortisol and other biomarkers and inflammatory markers that, again, were existing at the family level. So it's an extraordinarily rich and also simultaneously quite complicated data set to be working with, but here you get an idea of the levels of analysis that we have. So I want to give just a few examples of the survey-based measures, and then I'll talk about the biomarkers a little bit. We have a series of psychological constructs. Work-to-family conflict, schedule control, decision authority are some of the really important ones. We have social and economic measures. We look at turnover intentions. We look at income. And then we have a series of health self-reported outcomes largely related to health behaviors, so tobacco consumption, alcohol consumption, health conditions that employees might have, and sleep quality that's assessed at the individual self-report level. That is, how tired do you think you are, how well do you think you slept, which when coupled with the actigraphy data makes a very powerful source of information. We have a number of measured outcomes. For health markers, as I said, we have blood pressure, which was measured 3 times in a very standardized protocol. Body mass index, so people were, their height and weight was measured. And then we have a series of outcomes in selected subsamples that Kelly Davis will talk about further. I just want to show you a little bit about what the dried blood spot samples looked like. So we measured several things, and we have stored blood spots still. Basically, from the dried blood spots, we looked at C-reactive protein, we looked at glycosylated hemoglobin, HbA1c, and we did assays for cholesterol, both total and HDL. You can see on the far side that this is how we did the dry blood spots. You basically do a small finger prick, and there is a very great article reference to this by Osler, in which there's actually a video, so you can see what it looks like to be doing this. We ended up, and that's what the dried blood spots look like when they're done successfully. They're meant to fill a circle and get 4 or 5 spots. And then we actually did glycosylated hemoglobin right on the spot, so we could get that assay immediately because it seemed like a very good way to go. So this shows you the machine that we used for looking at glycosylated hemoglobin. And this gives you an idea of how we did the sleep actigraphy. So the watch, the actigraphy watch is here. You just wore it on your wrist. You could keep it on all the time. You were supposed to go in the shower, out, sleep with it, never take it off because it's monitoring continuously. And here you can see on the far side the kind of movement that people had. And when it's black, it means you're moving, and when it's white, it's sort of sleep or very, very quiet time. So you can see, for instance, a night before a work day and nights before days off. So one thing you see is that people sleep more when they're going to have the next day off. So Friday, people sleep much more. And then again, nights before work days are here. And you can again see that the black lines show movement. And when there are several dark black lines, so you start to see clusters, people actually are either waking up or moving a lot. So if you had a child that started to cry, or if you had a partner that jabbed you, or you were really anxious about work, all of these things would cause sleep disruption, which you can see are quite sensitively measured with this actigraphy. So you see not only the total time that people sleep, sort of classified by the size of the white line, but how disrupted that sleep is by the kind of dark lines.